first off, I'd like to thank Daniel for the invitation to be able to talk about something that I feel so deeply passionate about. I've been really captivated by the mind-brain relationship my entire life. Kind of how this pink pudding between our ears accounts for that magic of what it is to be human. Kind of our thoughts, our memories, our emotions. I've carried that through with me today, where now I'm a professor of neurosurgery, and I run an engineering lab in a center that works on creating neurotechnologies that can help kind of heal our patients and enrich our lives. And so kind of what I'm going to talk about is how we can use some of this neurotechnology to interface with our nervous system. And in the first round, I want to talk about how we can connect with our mind to heal our brain in the setting of stroke. And so the story really begins with a patient who I got to know who really inspired me. This is Rick, and here he is with his wife, Kim. Kim always referred to him as her Superman. He was a paramedic and really at the front lines of saving people's lives. Now, I want to introduce you to Rick's kryptonite. It was a small blood clot that occluded one of the arteries to his brain. And as a result of that, a significant portion of his brain died, leaving him paralyzed. Now, here's Rick 4 years after his stroke. And just as a little bit of neuroscience, what the dogma was that if you didn't recover function after 6 months, it wasn't going to get better. Here he is 4 years out, and he's doing a very standardized task where he has to pick up that marble and put it on the cabinet in front of him. And in many ways, that is a very, very heavy marble indeed. Because beyond not being able to pick up that marble, Kim has to help him get dressed every morning. He's no longer a paramedic. Can't go up to the second floor because he can't use his arm to reach up to hit the light switch. So the question is how do we fix Rick and the million other patients every year like him? And so when we think about the solution, I want to have you remember a couple different words. The first is contralateral. This idea that one side of the brain controls the opposite side of the body. The other word I want you to remember is ipsilateral. This notion that one side of the brain controls the same side of the body. Now, when we were first starting in this journey, basically the classic dogma at that time was that, again, one side of the brain controls the opposite side of the body. Right? So that's why when you injure one side, the other side is paralyzed. And most notably, the most common area affected is hand function. Now, if you ask Rick about his experience with his stroke, here's what he'll tell you.
All I really wanted to do was to be able to hold her hand. At the very beginning was to hold her hand.
So beyond the classic notion that we use our hands to touch the world around us. And if you want to have a sense of how badly it affects you, wear a sock, even just for 3 hours. You're going to find you can't groom yourself. You're going to have trouble putting your clothes on. But it's also beyond a mechanical organ. It's an emotional organ. It's how we not only touch things, it's how we touch people. And so again, how do we fix Rick? And fixing the brain is different from how we think about fixing the body. So when we have a broken bone, we realign in space. We put it in a cast, we put it in a splint, and eventually that bone grows back together. It's the same for an artery if it's lacerated, or skin if we get cut, we put stitches in. But for the brain, how do we fix a broken brain? How does that happen? Well, we can't put a Band-Aid on it, we can't put stitches in it, we can't put it in a cast. So rather than realigning in space, we need to realign in time. So what do I mean by that? Well, the brain is a truly dynamical organ, right? From the single neuron to large-scale neural populations, the information is organized by time scales. It's how we encode information at the single neuron level and how we organize different neural populations to process different components of information. And so the way we can tap into that time scale is with a brain-computer interface. Now, brain-computer interface has really 3 parts, fundamentally. Sensors, these are electrodes that record signals from the brain in some fashion. computation. It's a computer system that is taking those electrical signals, digitizing them, and then analyzing them so we can understand the intentions of that brain. And then fundamentally converting that intention to some output or machine command, whether it's a cursor on a screen or a robot. Now, historically, we used brain-computer interfaces for people with spinal cord injuries. The brain was intact, but the outflow was impaired, whether it be the spinal cord injury or neuromuscular disorders. And historically, people said you can't use a brain-computer interface for stroke because that area where the intention is present is gone. So we set out to challenge that notion. So again, the classic understanding is one side of the brain is injured, the other side can't move. But if you ask Rick, he'll tell you he can imagine moving his hand, he can try to move his hand, he just can't actually do it. And why is that? Well, one of the things that we discovered was that there is a portion of the brain that's associated with same-sided limb movements. And that's on the uninjured side of the brain. It's that ipsilateral side, if you remember me using that word. Now, in addition, it had a distinct physiology. Now, we can look at, again, thinking about timescales, we can look at different frequencies in the brain. And I think about these different frequencies almost like radio stations for neural circuitry. We can dial into them to find these different rhythms, and that allows us to dissect and parse different cognitive intentions. And so one of the things we discovered is that for ipsilateral signals, that it had a slower frequency than contralateral signals, which had a higher frequency. Now, the other advantage of that, beyond being able to separate ipsilateral and contralateral intentions, is that that low frequency allowed us to detect it non-invasively. And so we created what's called the IPSI-hand system. Now, again, a brain-computer interface has three parts: sensors, electrodes on your scalp; computation, a wearable computer on your forearm; output, something that opens and closes your paralyzed hand when you think about it. And so kind of here's what the system looked like in the early prototype phase. Here's Rick putting his EEG headset on. That's the computer he'd wear, the robotic exoskeleton that opened and closed his hand. And when you'd think about it, it would move. Pretty cool. Now here's what the system looks like now: sensors, computation, output. And so there's another concept I want to introduce you to, because there we're realigning in time, meaning that he thinks about it and he can control his paralyzed hand. But I want to introduce you to this idea of Hebbian learning. When neurons are firing at the same time, they eventually form new connections. That's called Hebbian learning. So that things that fire together, wire together. And we can now use that system and that notion with our brain-computer interface to help heal Rick. And the idea is that when he uses it, he uses that uninjured part of his brain to control that robotic. But as he uses over time, will that lead to new neural circuits forming so that eventually that uninjured side of the brain takes over control of his paralyzed hand? And let me kind of put this all together in an animation here. So again, that area in blue, that's primary motor cortex. The area in green, premotor cortex, the area that's doing the planning. Now again, we plan our movement. We then send the signals from our primary motor cortex down the spinal cord to the peripheral nerves and then to the muscles of our hand. Again, that's how we do all the normal stuff, whether it be brushing our teeth, putting our clothes on. And then Rick, and like a million other people, basically that area dies in the setting of a stroke. It loses blood flow and it dies. Now, but again, those intentions are still preserved. The execution is lost, but the intentions and the plan to move is still present. And that's on the uninjured side of the brain. Now, additionally, that has a separable physiology, and we can detect that separable physiology non-invasively, right? So again, so the patient wears a simple headset that can be applied with one hand, and when they think about moving their paralyzed hand, that robotic exoskeleton, first off, the system detects the intention to move, and then that robotic exoskeleton moves their hand. Now, but as they use it over weeks and months, what happens is that's giving them sensory feedback. Signals are coming back up to the brain as the brain and that premotor area is firing, so that eventually that planning area of the brain becomes an area associated with execution. And that uninjured side of the brain takes over control of that paralyzed hand. And you don't need the brain-computer interface anymore. Again, that's a nice animation, nice video. The question is, does it actually work? So here's Rick a few weeks after using the IPSY hand system. And he's again going to try to pick up that marble. And that was a big moment for Rick. But I'll tell you what was a big moment for me. A few weeks later, Rick flagged me down. He said, Dr. Leuthard, I just want to let you know, I can put my pants on again. And in that moment, I'll be honest, more than any paper, any patent, any award that I've received, that was the most important moment of my career. Because I knew I gave a man his dignity back. And I knew that it had the chance to help hundreds of thousands of patients like him. Now, here's what his wife will tell you a year after using the system.
This is the last year. When he started, it was in a fist, and he couldn't do anything. And just seeing him come back and being able to hold my hand and seeing the joy in his face from doing the simple things, and so I'm getting my husband back, and every day there's more improvement.
So, and Rick was not alone. We completed our clinical trial with this system. It was featured on the cover of Stroke, and 70% of the patients also had a significant improvement like Rick. And I think what's so cool about this technology is that it's not a drug, doesn't require surgery. We're simply using a technology to harness the power of your own thoughts to change the wiring and the structure of your brain. Now I want to take a reverse tack, because what happens when your thoughts are what are unhealthy? How do we change the brain to have better thoughts? Because the honest truth is, in addition to stroke, there's a reason that millions of people out there can't get out of bed, and it's not because they're paralyzed. It's because they're suffering from the crushing weight of depression. And so when we think about depression, again, we now have to take a different tack and think about that pathologic disease. And it involves an imbalance of certain networks in the brain. And I'm going to just go through these quickly here. First is the default mode network. Those are the parts of our brain that are involved with our internal referencing. It's quite literally our inner cosmos, how we kind of internally process information in our own mind. That's our inner world. There's a central executive network, and that's the parts of our brain that are involved with engaging with the outside world, attention, motor movement, vision. And then there's what's called the salience network. This is the network that attributes emotional value to different experiences that we have, either externally or internally. Now, when you become depressed, clinically depressed, there's a dominance of your default mode network. You quite literally become trapped in your own mind. That you exclude the external world. The emotional attribution that you give is to things that are negative, and you get trapped in that cycle. And so we need to break that network imbalance. So how do we sculpt the brain to improve our thoughts? And so for our approach has been a two-prong approach. And honestly, it's like making a really good cookie. First, you got to make the dough malleable, right? Then, if you're making a good cookie, you have to have a good cookie cutter or a framework to mold that dough, and that's going to give you a nice cookie. Similarly, to make the brain more plastic, we're going to use what's called vagal nerve stimulation. I'm going to talk all about that in a moment. And we're going to combine that with a framework to shape the information in your brain in a healthier way. We're going to use digital therapeutics. And I would argue that the combination of those two is a radical new approach is a radical new approach to mental health. So let's go through this. So first off, to change the highest level of your thoughts, you actually have to affect the most primitive part of your nervous system. So again, that primitive part of your nervous system, which really maintains the homeostasis of your brain and your body, is called the autonomic nervous system. Again, it's split into two parts. There's your sympathetic nervous system, and this is the primitive part that was evolved to allow us as cavemen to survive when a lion or a tiger would jump out at us. It's what dials our system up. It increases our heart rate. It increases our blood pressure. Our pupils dilate. It increases inflammation. It's a system that in the modern world is too often and too active for too long. Now, opposing that system is the parasympathetic nervous system. That's kind of our rest and digest system. It's what allows us to relax, consolidate, bring our blood pressure down, reduce our heart rate, reduce our inflammation, and learn. And that's us dialing down. Now, that's the system that we need to capitalize on to enhance our brain's ability to essentially reset. Now, that system, the parasympathetic nervous system, is primarily governed by two spaghetti string-like nerves in our neck, the vagus nerve. Vagus is Latin for wanderer. And the reason for that is that nerve innervates pretty much all of the organs in our body. Now, when we stimulate that nerve, it has widespread applications. And I've been a neurosurgeon. I've been implanting these now for vagal nerve stimulators for about 15 years. And when you stimulate it, it feeds down the nerves in the body. That is essentially right-setting the balance between the parasympathetic and the sympathetic nervous system. But importantly, when you stimulate that nerve, it goes in the opposite direction, back up into the brain. And when you stimulate the vagus nerve, that boosts synaptic plasticity. What that means is that it's allowing the brain to change its connections. And then when you change its connections, you can improve your level of cognition. Now again, as I mentioned, I'm a surgeon, and this is what a standard vagal nerve stimulator looks like. Again, it requires an incision in the neck, and we use this to treat medically refractory epilepsy. But this is not a scalable solution for depression. We already suffer with the issues of mental health associated with stigma. People don't want two incisions on their neck and a hockey puck implanted in their chest to further ramify that stigma. So we have to create something non-invasive to access this physiology. So let me tell you about kind of what I think is the critical neurohack. Basically a non-invasive on-ramp to the vagus nerve. And basically, there's a branch of the vagus nerve called the transauricular branch that basically innervates the skin in your ear, right there. So if you stick your finger in your ear, that area of skin that you touch, that's the area of distribution. And if we stimulate that portion of your skin, we stimulate that nerve, and that's going to feed back and give us some of the benefits that we get with vagal nerve stimulation in terms of synaptic plasticity. And here's what the system looks like. It looks like a Bluetooth earpiece. Again, those gold discs that you see are the electrodes that can stimulate the nerve. And again, it's wirelessly connected to your iPhone. So once we start stimulating, again, we are in a situation now where now the brain is now being stimulated in such a way that we're affecting synaptic plasticity. And we now have the opportunity to reshape those pathologic brain networks by putting beneficial information in. So how do we do that? Well, we use I'd say the second most powerful tool for manipulating neurophysiology, digital media, right? And so one can imagine a use case. Maybe you're driving to work, you have your ear stimulator in, and that's making your brain more malleable. You use your iPhone, and that's giving you content that can shape your brain in a positive way. That's the cookie cutter. And just to walk through some use cases of how we would legitimately use this. So one of the things we know is that people with depression can benefit from cognitive behavioral therapy. Cognitive behavioral therapy is basically a formula of questions that you can ask to challenge pathologic thinking, such as I'm bad, I'm ugly, I'm dirty, whatever, I'm alone. And you can also encourage behaviors that, when you do those together, reset people's emotional setting. Now, but combining that on the mobile phone with vagal nerve stimulation makes the brain much more receptive to that type of information, and it makes it synergistically better. Similarly, a big problem today is PTSD. Already, virtual therapy is becoming an important tool for what we call exposure therapy, where again, veterans returning from wartime scenarios, they have pathologic fear and panic response to relatively innocuous stimuli. And they have to unlearn that fear response. And again, with vagal nerve stimulation, you can accelerate that capability of unlearning that fear response. So kind of thinking about where this goes in the future, imagine creating an ecosystem where this combination of vagal nerve stimulation with digital therapy, and also using all the tools that e-commerce has used to really understand you to the T, so that now we can use those same type of systems to not enable you to buy a sock or purchase a shoe or a ticket or a download, but rather optimize the information that you receive to put your brain in a better place. So that's not just a better cookie. That, in my opinion, is a radical new approach to mental health. Now, these are just a couple examples. So where is all of this going? And I like to describe what I call Pong Moments. So in 1972, Pong came out. And there was an article in Time that talked about Pong, where people were lined up for an hour outside this bar named Andy Capp's to play Pong. Now imagine showing those people, they're kind of waiting around to play Pong. You showed them something 30 years later, Xbox 360 in 2002. It simply would be nearly inconceivable. Also, if you look at it in reverse, the computational power for Xbox 360 back in 1972, it did exist. It just cost $9 billion, and the computer was half the size of a football field. So now it's a toy that sits in our living room. The transition is dramatic and oftentimes beyond our imagination. Now let's fast forward another 15 years. And now you show that person who was waiting in line at Andy Capp's virtual reality. It quite literally is the stuff that science fiction was made of at that same time. It wasn't possible. But now it's everyday, commonplace stuff. So what are some Pong moments that exist for neurotechnology? Again, this we published in 2004. This is the first time that somebody used their brain to control a device using invasive cortical physiology. And quite literally, they're playing Pong. 7 years later, that was translated into an implantable device that allowed this patient with a spinal cord injury to reach out and touch his wife's hand for the first time. That's a relatively rapid transition. But I think we're going to see that even more rapidly, because in addition to kind of the notions of restoration, we're also going to see a whole panoply of applications for this. Can we start to think about cognitive augments? If we can restore function, can we make it better? Are there Pong moments today that are informing us of a dramatic future? Well, yes. This was published in the New England Journal of Medicine. If you put an electrode in the medial portion of the temporal lobe, you can enhance your memory. And almost ask yourself, if you could have a minimally invasive procedure that could improve your intelligence and your memory by 10%, 20%, would you do it? Would it make you more competitive in the workplace? It's a question that we need to ask. Let's take it even a little bit further. If we can decode information from your brain and we can encode it, meaning I can put information in the brain, can we start sharing thoughts, literally? Is that possible? Is that the stuff of science fiction? Well, again, here's a Pong moment. This is published in Nature, where again, with two mice, they basically linked up their brains so that they could share information back and forth so that they could accomplish a single task. That was a Pong moment. Let's take it even further. If we can encode information and decode information, we can save that information, right? Can we envision a scenario where we're downloading experiences so that, for your lunch break, you can be a rock star or you can hit the deepest state of meditation? Is that possible? Well, again, published in 2013, I thought this was a Pong moment, where they are able, using optogenetic techniques, which was mentioned earlier, to create a false memory in a mouse. So all these things are going to happen. So again, I think when we think, and again, it's a perfect place to have an exponential curve, because we are right here when it comes to this type of technology. We are quite literally, in the next 30 to 50 years, going to see a rewriting of the fabric of our human experience. And I think fundamentally, it's going to only be limited by our imagination. Thank you very much.
Thank you, Eric. Amazing. So you're not the typical neurosurgeon. You've also written science fiction, and you're creating science fiction. I remember playing Pong as a little kid. How do you catalyze this sort of innovation amongst other neurosurgeons and medical scientists to sort of see what's happening?
That's a great question. So I think that one thing fundamentally, and I run a center, it's called the Center for Innovation in Neuroscience and Technology, and we routinely have what are called invention sessions. And basically, we bring together people who don't normally get together. One of the physicists in my center jokes, like, the only time a neurosurgeon gets to meet a physicist is when he cuts them open, right? And so but we regularly bring in computer scientists, mathematicians, physicists, neuroscientists, engineers, and we talk about both the problems of clinical medicine, but we also importantly talk about what's new. And that invariably leads to kind of a nonlinear conversation where we create some new technologies, some of which is which I showed you today.
That's an example of really first understanding an unmet need, whether it's a patient with a disability, bringing new minds together, kind of like we're doing here, and then maybe even trying some of these technologies early, trying an Interaxon Muse with a patient, or some of your prototypes.
Yep.
So, any last thoughts?
No, it's clear that this intersection, things like exponential medicine, is what needs to happen to basically not only catalyze the new technologies, but also, I think, importantly, catalyze the considerations and ethical and social implications of them. So because the more we are prepared to understand this coming future, the more likely we can use all these things positively.
Great. Thank you, Eric.
Thank you. Okay.